Bone infection. In this occasion, I will be presenting a case of osteomyelitis I encountered during my summer rotation in Brooklyn. Since I only took the patient's last exam in July 2017, first I need to backtrack through the patient's priors for a better evaluation of the progression of this pathology. Patient history. In 2014, a 50 years old male patient came in for a right foot x-ray. His chief complaint was pain and swelling of the second toe, which was also black and blue. There was no trauma. In the doctor's report, he said that there was degenerative changes at the navicular and cuneiform joints, right here, a presence of hallux valgus deformity, and we can see it in this side coming out. A flexion deformity of the DIP joint at the first digit, this one, and a flexion deformity of the DIP joint at the second digit with soft tissue swelling of the second digit that we can see all around here. The doctor couldn't exclude fracture this time because of the way of how the distal phalanx projected over the middle phalanx of the second digit, but a follow-up study was recommended. Breaking apart the doctor's report. So hallux valgus, or commonly called bunion, is the progressive foot deformity of the first MTP joint, and we can see how it comes out on this side. This can be painful because although it looks just like a little bump, what is really happening is that the anatomy of the foot is changing, with the big toe pointing towards the second. In the second part of the report, flexion deformity involves abnormal position of the three joints in the toe. So we have here the three types: a mallet toe, a hammer toe, a claw toe. A claw toe is an MTP hyperextension and PIP flexion deformity. A hammer toe is an extension of the MTP and DIP joints accompanied with a PIP hyperflex. A mallet toe is a flex of the DIP joint. If the toe deformity is very painful, then surgical repair is performed. In 2016, the patient came back and his status was post-amputation. As we can see here, the first, the second, and the third digit were amputated. The first one in the distal part and the second and third phalanges are missing. This time the chief complaint was foot ulcer pain for 2 weeks. A foot ulcer is an open sore of the foot, and this can be deep and involve the tendons and bones. People with diabetes and people with poor circulation are more likely to develop these ulcers. In the doctor's finding were reported sclerosis involving the navicular bone and its articulation with the cuneiforms. Sclerosis, when describing a bone, is defined as a pathological thickening of the bone. Usually, one area of the bone will show this increase. In this report was also noted a healed oblique fracture of the distal shaft of the fifth metatarsal bone. And we cannot really see it in the AP view, but we can see it in the oblique. And this is why we take a minimum of 2 views, because some fractures are not possible to see in one image, but we can see it in this oblique. Most importantly, because of the high risk of bone infection, the doctor recommended an MRI. Osteomyelitis is an infection and inflammation of the bone or the bone marrow. It can happen if a bacterial or fungal infection enters the bone tissue. It can be through the bloodstream, or it can be due to an injury or surgery. Vascular deficiency or poor blood circulation can cause an infection to develop from a little scrape or a cut, usually in the feet. Poor circulation prevents white blood cells from reaching the site, leading to deep ulcers. People who have diabetes might also develop osteomyelitis in their feet if they have foot ulcers. In May 2017, the patient came back, and his chief complaint was full ulcer pain. This time, I was able to find the text notes. In the notes was said that the patient had had surgery in his toes removed 2 years ago due to an injury. This referring to 2015. It was also noted that the patient had pain and he had an ulcer that was not healed. This ulcer was located at the bowl of the foot for a few months, and that at the time the patient's foot was wrapped by the doctors because of the swelling. Also, this time the tech had asked a question to the patient if he had diabetes or history of it, and the patient had denied. The doctor's report was no different than the previous, but he also suggested osteomyelitis of the second metatarsal. In July 2017, the patient came back. His status was. In this slide, we can better appreciate the progress of this pathology through the years and see how in 2014 it started with the deformities of the DIP joints over here, and mostly the swelling and pain at the second toe. And after the amputation in 2015 of the distal phalanx of the first digit, as the phalanges of the second and third digit, through 2017 after the second amputation, when the infection started getting in the metatarsal of the second digit, and how they cut this part. This case was very interesting to me, not only because it allowed me to see the progress of this pathology through the years, but it also because in the making of this presentation, reading to the doctor's report and reading to the text notes, it allowed me to see the importance of history taking and how this is one of the most valuable opportunities that we have as techs to gather all this information and contribute to the diagnosis. How important it is to use our lead markers to mark the right anatomy, and how when we are trying to obtain this information from the patients, not just to listen to what they're saying, but listen to the stuff they're not saying and trying to gather more information using the secret 7 that we learn in patient care. Well, I hope you enjoyed my presentation. Thank you.